Welcome to Healthy Focus, the Duke Raleigh Hospital Community Education Series.
Please join me in welcoming Dr. Matthew Ellison.
Thank you. All right, well, again, thank you for everyone coming this evening. I guess this is the first of these lecture series for this year. My talk tonight will hopefully be talking about a good part of the body, not just the pathology and disease part of it. I'm going to talk about some things that are kind of tangents to tonsils. And so hopefully you'll find this interesting. I hope with some new things you didn't know about the body and tonsils. So we call this Lord of the Waldyre's Ring in honor of the Lord of the Rings movies that are out recently. We could have called it something a little bit more, boring, the tonsils and associated lymphoid tissue. That's maybe the more proper name. But tonight we're going to be talking about the tonsils, the good, the bad, and the ugly, which is a Clint Eastwood movie. We're going to talk about where tonsils are, where they came from, what they do or supposed to do. We'll talk about the bad, which is tonsil cancer, and talk about the ugly, we call tonsil infections and enlarged tonsil. So the good. Tonsils are located in the back of the mouth, at the junction of the oral cavity and the oral pharynx. This is a diagram of that, showing the uvula here in the middle, this being the back of your palate or the roof of your mouth. And then either side you have a tonsil. It's about the size of a large olive, although it can be much, much bigger than that. It can be much, much smaller than that. This is kind of a cartoon showing the same thing, that in the back of the mouth, the junction between the oral cavity and the oral pharynx, or the throat, there's this little mound of tissue called your tonsils, located on the side. There are muscles all around it. There's muscle in front and a muscle in back, muscles in the deep surface of it. Tonsil develops within a structure of the neck as an embryo called the branchial arches, and specifically a part of that called the second branchial pouch. Now the branchial or pharyngeal arches are a pretty fascinating part of human development. Now this is a human embryo at 5 weeks gestation, and shaped kind of like a little shrimp. So the head is up here. This would actually be the eye later on, and then there's a space for the ear. And there's these little mounds of tissue called the pharyngeal arches. And there's 5 of them, 1, 2, 3, 4, and 6. The number 5 does not develop in mammals. And this is a cartoon showing how these arches correspond to areas on the surface. More interesting part of it is what happens on the inside. So this drawing, it's kind of hard to visualize this, but remember that this is a 3-dimensional structure. And again, think of it as a little shrimp, and if you were to divide that horizontally from the head down to the foot, you'd get a picture that looks something like this. So there are these arches, these little mounds of tissue on the side. And these actually, in other animals, would develop into the gills. So this is an example of a shark, and they develop these gill structures, or gill arches, that correspond to these pharyngeal arches. In mammals, of course, that goes away. And that's what, on this drawing here, on the right-hand side shows that 5-week-old embryo, or maybe even 3 or 4 weeks, because there's no feet. Now that develops on into the human form. Down the other side is the fish. So these arches don't go away, they become the gill structures. There's a famous phrase, ontogeny recapitulates phylogeny, which means that the the way that an embryo develops into its final form goes through all the phylogenetic or the other so-called lower animal forms. Not really lower, they're just different. So that's a very interesting thing. Let's see. So this is a more simple diagram showing these different pharyngeal arches and the pouches in between them. The first one would form your ear canal on the inside, your eardrum right there in between, and then the eustachian tube, which goes to the back of the nose. The second pouch is where the tonsils will form. Now the third pouch becomes your thymus gland and what's called the parathyroid gland, which is involved in calcium metabolism in your body. And the sixth pouch becomes, again, a parathyroid gland and another body called the ultimobranchial body, which we don't know exactly what that does in humans. So again, you can imagine that if these were connected, they could be connections to the outside, and that would be like a gill. But again, in people that goes away. There are some situations where a person actually has a little of that connection still there. We call it a branchial fistula. So a little baby might have a little place on the neck that weeps mucus all the time. That may actually be a little bit of a branchial opening. So the name Waldeyer itself comes from, which we titled the topic today. Waldeyer's ring refers to not just the tonsils, but a whole ring of tissues like the tonsils at the back of your throat, which includes the tonsils, the adenoids, which are on the very back of the nose, the lingual tonsils, which are on the back of the tongue, and then mucosa-associated lymphoid tissue, which means you have little tiny patches of the same kind of tissue scattered throughout the throat. It's named after a scientist, Dr. von Waldeyer-Hartz, and he actually was also the same guy who came up with the term chromosome, and he was also kind of consolidated the neuron theories of how your brain and your nervous system work. So he did quite a bit. And he's actually more known for his studies of the eye than he is this Waldeyer's ring. Now, there's no relation to J.R.R. Tolkien, who's the guy who wrote Lord of the Rings. So I think he's much nicer looking than him. So the tonsils, we talked about those. The adenoids on this drawing are here in the very back of the nose. If they were big, you can imagine that they would block off the eustachian tube going to the ear, but also just the nose also. Lingual tonsils are the tissues in the back of the tongue. And they can be up higher here, but they're usually down lower. And this is a diagram looking from above, this mounted tissue in the back of the tongue. And they normally have a very nodular, kind of irregular appearance. That's just their normal appearance. And then the MALT, the mucosa-associated lymphoid tissue, there's not really a place that is, it's everywhere. And so this diagram is just another representation of the adenoids, the tonsils, the lingual tonsils. Now, the tonsils are part of your lymphatic system, which is part of your body involved in fighting infections. Now, the lymphatic system, at least part of it is something physical. The part of your immune system that's not so physical is kind of cells that are circulating everywhere, but there's a part that's actually a physical part. And you can think of it as a network or a web-like system of nodes and lymphoid channels that connect these lymph nodes. So the tonsils are part of that active infection-fighting function. They also have a very important part in keeping a memory of previous infections. They produce a lot of antibodies, and particularly the type of antibodies that are found in your mouth and your throat. That's important for fighting off infections that come at you through your mouth and your throat. This is a little diagram talking again about the lymphatic system. It begins very early on with a vein, and off of that some cells begin to differentiate, forming a little thing called a lymph sac. And then around this, and this will happen in various parts, and these lymph sacs will all connect which is the purple diagram is meant to represent. And then into that sac, these primordial cells will come and eventually develop into a lymph node. So, and I'm not going to talk too much about this diagram other than just to kind of show how complicated this whole system is. There's various chemical signals that the cells send back and forth. Quite a complex process of developing your lymphatic system and your lymph nodes. And as much as we understand about it, there's still a lot that we don't. The lymphoid system is throughout the body, so within the gut, within the neck, within the axillary or armpit area, the inguinal area, this nasal-associated lymphoid tissue like the molt that I talked about. Now, tonsils themselves also aren't just a lymphoid function, but it's all the supporting tissue for that. We call it scaffolding. That includes the surface itself, the collagen, the connective tissue, and that scaffolding forms crevices, or what we call crypts in the tonsils. And those crypts can be a source of a problem, especially as the lymphoid part kind of regresses or gets a bit smaller. These crypts become more prominent and deeper. Like I said, it also includes blood vessels and nerves, mucus glands. The surface itself is similar to the inside of your cheek, which we call a non-keratinizing epithelium. So epithelium is just the surface lining of your body. Non-keratinizing means that it does not form flakes of skin like the outside of your body does. So these are some photographs, or some microscope photographs of the tonsils. So the surface is here, which looks somewhat similar to what the surface of your cheek would look like. And underneath that are these lymph node type collections of immune fighting cells. They organize themselves into little groupings. There's connective tissue in between them. There's blood vessels. There's muscle beyond that. So the now this slide. I'm sorry, I didn't have this slide in your handout, but this is talking about a little bit of the controversy about tonsils and tonsillectomy that I'll be talking about later. What I talked about was all now just the good parts of your tonsils, and so there was a lot of controversy about taking them out. What would that do? Don't you need your tonsils? So back in the 1950s, there was a doctor out of Australia who did some studies about some of the polio outbreaks that were happening at the time. And he found that, in his study, 35 out of 39 cases of bulbar poliomyelitis, which is the more severe type, patients had their tonsils out previously. And that's pretty significant just by the numbers. And his theory was that the tonsil surgery exposed or traumatized the nerves around the area. And we know that the poliovirus is a virus that attacks the nervous system. Other theories came about, such as that maybe you don't have to have your tonsils to develop an immunity, but they help provide a more rapid response. So, for example, with polio, these children were getting the bulbar poliomyelitis, and weren't getting the more mild types. So there's been a lot of study about this sort of issue over the years, and the antibody levels do indeed decrease after your tonsils and adenoids are removed. But those levels return to normal within about 3 months. There was a lot of concern also about vaccines, especially the oral vaccines. Like polio used to be an oral vaccine, which is a live virus. And the thought was, well, if you don't have your tonsils, how are you going to develop an immunity to it? So that question was never totally solved, but probably just by the power of vaccinating so many people, it wasn't significant. And today, most vaccines are either killed viruses, like the polio vaccine of today, or killed bacteria, such as acellular pertussis bacteria vaccine. or the vaccines are given by shots, like the flu virus, which is a live virus, or live vaccine. So that's a little bit about the good part of the tonsils. I'm going to skip to the ugly part of your tonsils, and that includes tonsil infections and tonsil enlargement problems. So with tonsil infection, this is a pretty gross picture. I'm sorry, I shouldn't have put it in there. This is someone with acute tonsillitis. And you just see how much that must hurt, because they got all this kind of exudate on their tonsils. They're huge, they're red, they're painful. People often have very high fevers, chills and sweats. They can barely even swallow. Often get dehydrated. On examining them physically, you find the tonsils are large. Sometimes kissing tonsils, and these are just about kissing. There's exudate and they're red. There's also chronic tonsil problems, and this is a person who looks just about as bad, but there's no exudate, and this is just someone who kind of lives with their tonsils like that. They have very low amounts of sore throat. They usually don't have any fevers. They have some bad breath often. They often have problems with tonsil stones, which is debris that gets caught in those crypts or those crevices I talked about. And they can get acute infections on top of their chronic problems. Now, chronic tonsil infections are actually a very interesting problem, and we've learned a lot about them in the study of another kind of infection called a biofilm. So, chronic tonsillitis means that you have a chronic infection, and it's obviously not bad enough to totally take you out of commission. You know, people don't stay home from it; just kind of struggle day to day with it. But still, they're living with this infection. And the question was always, well, why don't the body take care of it? Why can't the body get rid of this chronic infection? And there are other similar situations. Some dental problems, people just can't get that cleared. People will get infections of implants, heart valves, things like that. And the question was, why can't the body recognize that and get rid of it? It happens with IVs or central lines. People are in intensive care unit to get these infections that they can't seem to clear. And initially, those implants, well, obviously they were taken out because they were a problem. We would study these and find this special kind of infection called a biofilm. This biofilm has subsequently been found in the tonsils and chronic sinus infections. And a biofilm is a very complex, almost organism-like growth of bacteria. Some people call it a slime layer. In this diagram here, the green are the bacteria. And the other colors, the pink and the red and the blue, are this sort of slime. This protects the bacteria that are underneath all of this. Makes them highly resistant to antibiotics, because the antibiotics can't get to the bacteria. Your own body's immune system can't get to the bacteria. And other things that your body might do to try to kill these, releasing chemicals and peroxides and things like that, can't get to them either. So these bacteria will kind of lay in there. Now, of course, the bacteria themselves can't get very much nutrition because they're underneath this stuff, but they don't really care. They just kind of hang out there. They're almost in a suspended animation, and slowly they'll find their way out and then start to divide. And then if they happen to get out and get killed, well, there's other ones that are still there to replace it. So biofilms are extremely difficult to clear up. This is another set of pictures. And I'll kind of focus on this top frame up here. The top series shows just the bacteria. And for a long time, microscope exam and staining of bacteria would just kind of show this part of what was going on. But with the recognition of what biofilms are, different staining techniques have been used, which is this bottom panel showing how much is also going on besides just the bacteria growing. There's all these different chemicals and there are proteins, lipids, this biofilm slime that's also there. This kind of study is actually fairly new. With some sorts of studies, you wind up killing the thing you're looking at in order to get the picture of it, which is fine. But with this newer technique, they're able to stain and mark things using things like fluorescent labels that allow them to study it but not kill the process that was going on. So they're able to study as this develops without stopping the process but which is what had to be done before in order to take the picture of it. So that's also helping. That's being used in many different areas of medical research. So, biofilms, like as I mentioned, they're associated with dental cavities and gingivitis, chronic sinusitis, implants, so things like heart valves, joint replacements, central lines. Legionellosis is a disease strongly associated with biofilms. It's a lung disease that first kind of broke out in, I guess, some legion hall. So that's partly how it got its name. Basically, water pipes would be contaminated with this biofilm, and it would kind of expose everyone in the place to that organism. Tonsils are bad enough of a problem in terms of the chronic infections that they're actually, in the case of beef or cows, considered an SRM, which is I forget what that stands for, but basically a restricted material. So it's something that they try to get out before sending off the rest of the animal to be processed. So, next type of infection is called peritonsil abscess. So, as you might remember from those first diagrams, the tonsil sits back there in the back of the throat and is surrounded by muscle, and there's a potential space between the tonsil and the muscle. It's not an actual space unless something gets in there and makes it a space, which is what happens with a peritonsillar abscess. So this is a CAT scan. It's taken axially, which means kind of across your face that way, kind of like if you would cut off the top of your head. But this is going down to the level of your jaw. So this would be your mandible or your jawbone. This would be part of the root of your tongue. In the back, you have your tonsils. And so on this person's left tonsil, this is the left side on a CAT scan, there's a darker area in the middle. And that's a fluid collection. In this case, it's a peritonsil abscess. So, oops, I'm sorry, that's incorrect, the words I have there. So people do have fevers, they have a horrendous sore throat, bad enough that brings them into the emergency room. So I forgot to change that slide, I apologize. These are some more pictures of that. This is someone who has a peritonsil abscess, so the tonsil's red, but the surface is actually still kind of smooth, so the problem is kind of behind the tonsil, pushing it all forward. There's also a condition called peritonsil cellulitis, and so sometimes in the process of forming abscess, the body forms this thing called cellulitis, or a phlegmon, which is basically a battle going on between the bacteria and your own body trying to contain it, and the body will either resolve this or wall it off into an abscess. So that's called cellulitis. Next problem is tonsil hypertrophy, which means enlarged tonsils. So this is an example of someone, here's that uvula in the middle, and these huge tonsils. Now they look red, but in this picture everything kind of looks red. So they really don't look that much more red than everything else in this picture. But they're kind of nodular, got these little crypts and things. There's no exudate over it, there's no redness really around the edge of it. So this is just enlarged tonsils, not infected. This tends to present with loud snoring, and children often picky eating because food gets stuck on these, so they tend to limit what they can eat. They'll sometimes have a hot potato voice, and in children it can also affect their articulation. The tongue gets kind of pushed forward by these big tonsils, and so there's certain words they can't pronounce. And we have various ways of grading that, 1, 2, 3, and 4, which kind of help us figure out how severe it is. This is usually a problem in children. Can be a problem in adults too, but it's mostly children. Tonsils grow until the early teenager years, and then tend to get smaller after that. Proportionally to the size of the head and the neck, they're largest proportionally at age 4 to 7. That's when you see probably the most kids getting their tonsils out because of large tonsils. They can cause problems with not just snoring, but actually sleep apnea or disrupted sleep. Children sometimes won't let themselves get to sleep apnea. They'll continually wake themselves up, and there's a term for that called upper respiratory distress syndrome. So they're not actually having apneas, but their brain is waking them up continuously to prevent the apneas, which essentially has the same effect on their lack of sleep. And so this is something that can affect children in school in terms of their attention and ability to learn and pay attention and all that kind of thing. Now the adenoids, which is another part of that Wall-Dyer's ring, can have the same problem. This is a picture of the back of someone's nose. So this white part here is the septum, which is the middle of the nose. And this kind of yellowish part here is the side of the back of the nose. And this is the roof of the nose in the back. And normally, where my red arrow is going here, that should all be open. Kind of like the darkness down here. That should all be open. But instead, this person has these huge adenoids actually kind of growing into the nose. And you'll see that in children, these huge, large adenoids. In that case, they're largest proportionally about age 3 to 4, so a little younger. But a child, even even younger toddler than that, can have huge adenoids like this. They tend to cause chronic rhinosinusitis, and rhinosinusitis is either sinusitis, sinus infection, or rhinitis, which is just a nasal passage infection. So a child will have a constant runny nose. The nose is always running. You look in the front of the nose, and everything looks fine. They don't have big swollen tissue, but still there's all this mucus, and it's usually big adenoids. In adults, they usually don't have chronic sinus problems from big adenoids, because the adenoids, like the tonsils, tend to shrink away. Can cause problems with mouth breathing in children, and this is significant because it can affect their facial growth. If a child is always breathing through their mouth, their teeth are always apart, so they have problems of dental growth, malocclusion, and they actually have they can have a slightly stunted growth of their midface, so the nose, upper lip area. Also causes problems with ear infections. So behind this large adenoid is supposed to be the opening to the eustachian tube. And so if that's blocked by big adenoids, they're going to have either ear infections or what we call otitis media with effusion. And otitis media means a middle ear infection, that's the space behind your eardrum, with effusion, which means fluid. So they might have fluid but not have an infection, which is, and parents always feel just terrible when this is discovered. Sometimes during a hearing screen, as in their kindergarten, they say, oh, your child having a hearing problem, and go in and they have fluid behind their ears. And they're like, well, how did we know? Then she never had an ear infection. And so this can present without ear infections, just fluid backs up, and they have a hearing loss. It's a temporary hearing loss, not permanent. It's just because the fluid's there. So we'll move on a little bit to talk about tonsillectomy and surgery for that. And there's various national organizations have come up with criteria that are sort of the standard criteria for when to consider tonsillectomy. And these are much more strict than past decades. And there has been a decrease in the amount of tonsillectomy related to that. We basically figured out that not everyone who has tonsils need to have them taken out. So by this, it's 7 tonsillitis episodes in a single year, 5 tonsillitis episodes a year for 2 years, or 3 tonsillitis episodes a year for 3 years. Now, 7 tonsillectomy episodes in a single year, that is a lot. And most people, if they have 5 in a year, they're ready to be done with the whole problem. So even I usually don't wait till I have 7 in a year before saying that tonsillectomy would help you. Other reason to consider tonsillectomy is if they continue to have tonsil problems and they have a lot of antibiotic allergies or antibiotic intolerance problems. And the other reason for tonsillectomy is not based on infection, but based on their size. So that'd be disrupted sleep. In children, some may have chronic bedwetting, which is called enuresis. They have behavior problems, poor school performance. There's also some unusual things like this PF-APA syndrome, which is children usually have periodic fevers, so they get fevers almost like a 2-week basis. Aphthous pharyngitis, which means they get aphthous ulcers in their throat on their tonsils, and obviously very painful. Aphthous ulcer is like a fever blister. And an adenitis, which means they get very large lymph nodes in the areas that drain from the lymphatic channels of the tonsils into the neck lymph nodes. And then also peritonsil abscesses. If someone gets a single peritonsil abscess, we usually drain that, often in the emergency room. And 90% of people who have one of those do not have another one. So just because someone has a peritonsil abscess doesn't mean they have to have their tonsils out. But once they get their second or certainly their third, then the pattern's been set that this is really not going to be a problem. It's going to go away, and need their tonsils out. So other reasons to get your tonsils out is chronic tonsillitis problems. This tends to be more adults. So they have chronic irritation, tonsil stones, bad breath, recurrent problems, which I talked about in the last slide too, but can affect adults too. And obstruction, again, not too often in an adult, but it can happen. Other reasons for tonsillectomy would be things like a significant difference in the size. Why are both sides different? Or an unusual appearance, and usually both of these together. I see a lot of people who have one big tonsil and one small tonsil, but they look normal, they're not changing, so you don't have to automatically take those out. So, final thing I'll talk about is the bad part, which is tonsil cancer. Now this is someone who has a cancer on the back of their tongue, which is not, this is actually not the lingual tonsils, it's actually the tongue itself, but it's the best picture I could find of that. So you can see there's ulcer here, there's some blood here, very angry looking thing. Tonsil cancers, we typically are talking about what's called a squamous cell, not squamous a squamous cell carcinoma. The squamous cell is basically the lining cell of the throat. You can have squamous cell carcinomas of your skin. It's a very common type of skin cancer. This is a non-keratinized epithelium, like I mentioned before. You can have other kinds of cancers coming from the tonsil tissue, including lymphomas, salivary gland cancers, sarcomas, which is a tumor of the connective tissue or the muscle. And then there are also other non-cancerous conditions, benign tumors of all these structures, the salivary glands, for example, and these family of disorders called lymphoproliferative disorders, where the lymph node cells kind of go crazy and get big. Now, it's not a lymphoma. These are usually associated with Epstein-Barr virus, which is a virus that causes infectious mononucleosis, or mono. We see these often in people who have immunosuppression. So, someone has to go in and get a bone marrow transplant or aggressive chemotherapy to kind of wipe out their immune system. And as it comes back, and they happen to have Epstein-Barr virus laying dormant in their system, they can develop these lymphoproliferative problems where the lymph nodes just go crazy. Now, tonsil cancers have several risk factors. The biggest one is smoking. This advertisement goes back to a time when us ENT folks recommended cigarettes. It says here, give your throat a vacation. Smoke a fresh cigarette. And these are not bad people. They were smart people. They had very good intentions. They kind of thought that the smoke and the menthol would kind of soothe things and make people feel better. Which actually, you can't see it on this drawing at all, but somewhere here it says, I think it says approved to age 6, which I can't imagine today saying that, but that was the thought back then. And and the tobacco companies would pay ENT doctors to get together and try out different cigarettes and say which one is better. And so this was Camel, but they all did that. There's some very embarrassing pictures of doctors sitting around trying out different cigarettes and multiple cigarettes in their mouth and stuff like that. So smoking is the big one. All these other things are risk factors to alcohol, especially heavy alcohol use, human papillomavirus, other viral infections like EBV. There's some question about whether acid reflux might contribute to it. And these bottom four, most people think that the risk, if you just drink a lot of alcohol, or you just have this, or you just have this, your risk isn't too bad. But if you do that and smoke, your risk goes way up. So we often see people with cancers that have several of these risk factors. Now I say that, but there are certainly people who have done none of these things ever and still develop a tonsil cancer. And those are usually people who have the HPV-associated tonsil cancer, or maybe one of the other ones, or maybe have acid reflux, or maybe just have bad genes. And that's what we sometimes consider loading the gun. If you have bad genes, your gun is loaded, unfortunately, and you just want to make sure you don't pull the trigger by doing any of those kind of things. When we talk about tonsil cancer, we have developed a staging system for that. It's called a TNM system. That's used for many different kinds of cancer. Basically, all kinds of cancers, you can find a TNM staging for. It incorporates the tumor size, the presence of node metastasis in the region, and also includes whether there are metastases beyond the lymph nodes or beyond that region of the body. And the main goal of staging this is to help with the prognosis. In other words, if your tonsil cancer is such and such of a stage, that implies that your prognosis is either good or bad. Helps us also to figure out what treatment options are best. Now, tonsil cancer has several very frustrating parts to it. It often presents late. Certainly no one would neglect a tonsil cancer if they knew they had it. So why do they present late? Well, there's often no pain. There's no bleeding sometimes, although often there is bleeding by the time it becomes a problem. Sometimes they don't have any problems with swallowing, at least in the early stage. And I've seen many people who their first presentation is a lump in the neck. They really don't have any problems at all in their throat. So, for those people who do choose some of those high-risk behaviors, we estimate that it takes about 2 years for a throat cancer to grow to the point that it's clinically detectable. And they figured this out by some very large studies, actually in India, where they did these huge mass screenings of people. And they have a very high incidence of head and neck cancer there because of how they chew their tobacco. And so people who they examined 2 years earlier didn't have it, but then 2 years later they would have. And they kind of figured out by looking at all the numbers that it's about 2 years probably from having nothing to having a cancer. And it's important to be very vigilant in one's own body, which is hard in the back of your throat or your tonsils. And it's almost impossible in the back of the tongue. And unfortunately, screenings have not been shown to help survival. That, again, came out of some of those really large studies that mass screenings, unfortunately, really haven't been shown to help. And we don't know what quite to do with this other than, again, looking at those people who do the high-risk behaviors and just being extra vigilant about teaching them what to look for and then doctors themselves looking carefully. Now, recently there's been what some people call an epidemic of tonsil cancer related to the human papillomavirus. Now, human papillomavirus is a very common virus. There are many different strains for it. Most of them are benign. It includes plantar warts, little warts that little kids get on their fingernails. It does include genital warts. Some HPV strains, though, are not so benign, and particularly the 16 and 18 strain, those are the ones associated with cervical cancer in women. It's also associated with the tonsil cancers from HPV. And this diagram shows several different things. I'll start off here with this one in the upper right. This shows the overall downward trend in the incidence of tonsil cancer, and this is in men who do not have HPV-type tonsil cancer, and that's the vast majority of them still. You see it's going down. Women, same thing. Incidence rate is going down. That probably has to do with the decreased rate of smoking overall in the United States. But there are some exceptions, and here you see this one group, which is men 55 to 64. There's an increase, and it's an increase in HPV-related tonsil cancers. In women, it's not so clear. It's kind of flat that way. So this is one of the reasons that that HPV vaccine is now recommended for all people, not just women. Now, most HPV lesions, just like elsewhere in the body, are not cancers. And it shows some examples of those. This is on the side of someone's tongue. This is a little papilloma. This is on someone's tonsil, a little papilloma. This is a raised kind of, I don't know how to describe that little funny-looking growth there. And you can see these anywhere. And one of the interesting things about HPV-positive tonsil cancer is that it tends to have a better prognosis. So, especially in the more advanced stages. So here's stage 4. This is someone who either has a very large tumor or who has cancer which has spread to another part of the body, or has multiple lymph nodes or very large lymph nodes. And in the HPV negative group, none of those people survived their cancer, 0 out of 10. Now, the HPV positive is still not great. It's only 4 out of 13, but at least some people were. Stage 3, again, not quite as advanced. They don't have any distant disease. They might have a large tonsil cancer. They might have multiple lymph nodes. Again, the number is kind of small, 3 out of 4. But all the way across, the HPV positive is better, except for the early stage. Early stage means that you have a small cancer just in the tonsil. It has not gone to lymph nodes, has not gone to other parts of the body. And so with that, it doesn't matter what type you have, because the outcome is going to be good. Treatment options for tonsil cancer include radiation therapy and chemoradiation, which means a combination of chemotherapy and radiation, often together. This has sort of become the standard way of treating tonsil cancers. The outcome is very good. There are some side effects, and some of them are lifelong side effects. Surgery, which used to be a mainstay part of treatment, has sort of changed its role. It's used for salvage. So someone gets, upfront radiation and chemotherapy, get an initial response, but then 3 months later things are starting to grow again. And so that's called salvage surgery. They can't get that treatment again. Their throat couldn't tolerate it. So surgery is kind of their only option. It's used as a pre-radiation or pre-chemoradiation. So sometimes people's tumors are just so big and huge, or they're blocking their airway, they'll get surgery first, and then treatment afterwards. Sometimes surgery is used afterwards, and this is particularly true if someone has a really large lymph node, and they get treatment, their primary site, and the cancer goes away, but the lymph node is still there. And so the question was, well, is that still cancer, or is it just scar tissue? That's not done so much anymore because we have different ways of scanning the body afterwards. It's called a PET scan, and it's able to look for metabolic activity in those lymph nodes. If it's all the scar tissue, it should be pretty bland and flat, but if it's still active, it'll light up. There's also been recently some interest in whether surgery might have a role again for the HPV positive patient. And this is particularly true for the stage 2 group, which is, like in this diagram, the number of patients is pretty small in that group because people tend to present late. But the thought was that, well, if you have someone with a small cancer just in their tonsil, and maybe 1, maybe 2 small lymph nodes on the same side, and it's HPV positive, would there be a role for doing a radical tonsillectomy and a neck dissection, which is a surgery to remove all the lymph nodes, and spare them the need for radiation and chemotherapy? So that's kind of hard to study that because we've already come up with a way that does treat them successfully. But still there's some interest, again, especially in the younger patient maybe, who's got a long, long life ahead of them suffering with these symptoms. Really, that's kind of where the interest is, but really for anybody, because radiation and chemotherapy is not pleasant, although it works very well. So tonsil surgery, and that ranges anywhere from tonsil biopsies to run-of-the-mill tonsillectomy. Adenotonsillectomy is very common in children where you're removing the adenoids and the tonsils. Radical tonsillectomy is where you're removing not just the tonsil, but part of the muscle around it. And that comes into play when it's a tonsil cancer. And these techniques are all very established. Some of the new changes are the tools that are available to do these techniques. Now the standard way we do tonsil surgery is with what's called monopolar or bipolar electrical energy. So these little pencil-like things that deliver a little electrical energy that can cut the tissue almost like a laser, but also control bleeding at the same time. And there are various shapes to these, so you can use them as an instrument to push the tonsil away as you remove it. This is sort of the standard way, I'd say. Some ENT doctors still do it with what we call cold steel, which just means they use cold instruments, the scalpel, and they have excellent results too. So there's no problem with that tried and true way. There's another technique called coblation, and this uses plasma energy. And plasma, even I really don't understand exactly what that is, but it's a superheated gas. The advantage is that the temperatures created with this are a lot lower than you get with the electrical energy. Now you can adjust the power of this electrical energy so you almost get to the same point as the plasma energy, but coblation has a lot of appeal. It's kind of the newest thing on the block, and it does a very good job too. The final thing I mentioned here is what's called transoral robotic surgery, and this is what this diagram shows. Robotic surgery is something that's been used for some time now, primarily in areas other than the head and neck. So it's used for abdominal procedures, for prostate surgeries, and in this case, what the robot does is basically allow you to get a whole lot of instruments in through a small little opening and control the tips of those instruments remotely. So this is a surgeon right here. He's sitting in this box playing a video game, basically. He's looking through a stereoscopic camera, so he's got binocular vision looking through this device. And he's looking, one of these instruments here is a camera. And it's a camera that's got two lenses on it. One goes to each eye, basically. And so he has a three-dimensional view of what he's working on. And this is a model, and he's got his instruments. So one's a camera, and a couple other ones are the instruments that actually do the work of the surgery. And there's actually enough room in here that an assistant can stand by the head of the surgery and insert another instrument. So you can do a lot in this small space that you couldn't do before. Now this is obviously a bit overkill for your simple tonsillectomy. I mean, you don't need all this for that. But this is useful for, say, the radical tonsillectomy, or maybe someone has a tonsil cancer that's kind of going into the tongue just beyond where you can see it looking directly. These cameras can be straight, which means the end of the camera goes right to what you're looking at, but they can also be angled. So the end of the camera with an angled bevel on the end actually looks down from where the camera is pointed. So even though the camera is coming straight in, it can be looking down the throat. So you get a better view than you can just looking straight from outside. So now I don't perform transoral robotic surgery, but there are some of my colleagues at the main campus that do this. All right, I think that's basically the end of my talk. I know I covered a lot of things. Some of the good parts of the tonsils, like where they come from, is pretty fascinating. The pharyngeal arches. What the tonsils do is also very interesting as part of your lymphatic system. Tonsil cancer is a bad thing. It's something that continues to be a problem. And the more common things that I see would be what I'd call the ugly tonsils. So tonsil infections, large tonsils, and that sort of thing. All right. And with that, thank you.